Uh, we are presenting an oncology session this morning, and I have two smart residents with me, Famida Mortaza and Tina Filfili. We're gonna start with Famida. She has an interesting case to present. Famida, go on. You're
Okay, so
muted.
I'll get started. Can everyone hear me?
Yeah, I can hear you.
Okay, and you guys can see the slides, right? But not the slide notes?
No, we just see your slide.
Okay, great.
If
So
you can
hi,
make it,
everyone.
can
My
you
name
make it
is
full
Famida.
screen?
I'm one of the PGY2s at UofT. I'll start with the first case. The first case is that of a 71-year-old female. She was referred to PMH ophthalmology by her optometrist for an asymptomatic retinal lesion in the right eye that was found on routine eye exam. She had no past ocular history. She did have past medical history of hypertension, which was well controlled on the appropriate medications. She did have a significant oncologic history. So 10 years prior to presenting to us in 2011, she was diagnosed with mucinous carcinoma of the right ovary, and she underwent a total hysterectomy and bilateral salpingo-oophorectomy and completed adjuvant chemotherapy with carboplatin and paclitaxel, which is a common chemotherapy regimen for ovarian carcinoma. Then 6 years later, in 2017, she was diagnosed with basal cell carcinoma of the skin on her chest, and an excisional biopsy was performed, which was both diagnostic and therapeutic with clear margins. Later that year, she was diagnosed with ductal carcinoma in situ of the right breast, for which she underwent a lumpectomy and radiotherapy. Then in 2021, 4 months prior to presenting to our service, she developed shortness of breath and dyspnea. She presented to her oncologist, who ordered a pan-CT and bone scan, which revealed metastasis to the right lung, hip, pelvis, and adrenal gland. And biopsy of the lung lesion revealed also an adenocarcinoma, mucinous type, which raised suspicion for metastasis from the ovarian primary that was diagnosed back in 2011. However, it was noted that there were some differences in the immunohistochemical profile between the ovarian tumor diagnosed back in 2011 and the most recent lung biopsy. Given the success of previous chemotherapy, she was restarted on carboplatin and paclitaxel. And when she presented to our service, she had already completed 2 cycles of chemotherapy. However, her systemic lesions continued to progress despite being on chemotherapy. So slit lamp examination revealed a visual acuity of 20/30 in the right eye and 20/20 in the left eye. Pressures were normal, and the anterior segment examination was normal in both eyes. The posterior segment examination of the right eye revealed a clear vitreous, and there was a focal 6 to 7 millimeter creamy white elevated retinal lesion with ill-defined borders and some intrinsic hemorrhages at the infratemporal arcade. The posterior segment examination of the left eye was normal. Here's just a closer look at the retinal lesion in the right eye. This is OCT of the macula. It showed an ERM with a central macular thickness of 390 microns. The ERM had been noted over the last 2 years per optometry notes, and the left eye OCT MAC was normal but is not shown here. This is a OCT through the lesion, which demonstrates thickening and disorganization of the retinal layers with no apparent involvement of the subretinal space or underlying cord. Fundus autofluorescence in the right eye demonstrated a hypoautofluorescent lesion, and the left eye fundus autofluorescence was normal. We then go on to the ultrasound, which showed a localized retinal thickening with a maximal thickness of 1.36 millimeters with medium to high internal reflectivity. So given all of this and a history of immunosuppression and all the testing, it demonstrated a primarily isolated retinal lesion with overlying hemorrhages, and her presentation was felt to be most in keeping with a viral retinitis, specifically CMV retinitis. And so intravitreal ganocyclovir was administered in clinic. We'll go on to our first poll question, just to gauge the audience as to what they think the lesion looks like. So which of the following appears to be most in keeping with CMV retinitis?
Give it just a few more seconds.
It's like these, like elevated.
Okay. See the results?
Okay, so that's what our inclination was as well. When we were treating this patient, her presentation was very classic for what a CMV retinitis would look like. So we'll go on and I'll tell you which photo later was the right one. So we'll take a moment to talk about CMV retinitis. It's caused by cytomegalovirus, which is a double-stranded DNA virus that is part of the herpes viridae family. It's most often associated and found in patients with HIV and AIDS, as it is an opportunistic infection. However, it can also be found in patients with severe immunosuppression from chemotherapy and autoimmune conditions requiring immunomodulatory therapy. CMV causes full thickness retinal infection that causes necrosis, scarring, atrophy, retinal breaks, and detachments. CMV retinitis can present in many ways. The first is a fulminant presentation, as shown in photo A, where you have hemorrhagic necrosis and white-yellow cloudy retinal lesions. It can also present as granular, as in photo B, where the retinitis involves the retinal periphery, and there's little to no necrosis or hemorrhaging. And it can also present as perivascular retinitis, as shown as in photo C, which is the classic frosted branch angiitis. And on H&E staining, we can often see CMV infected cells contain these eosinophilic, cytoplasmic, and nuclear viral inclusion bodies that give the classic owl's eye appearance. So this was our patient reassessed 1 week after the intravitreal ganocyclovir. As we can see, the retinal lesion was persistent. It was unchanged in size. And by now, the patient had completed 3 cycles of chemotherapy and had repeat imaging, which showed interval progression of systemic lesions. At this point, there was a suspicion for retinal metastasis, and a decision was made to pursue a retinal biopsy. So this is the results of the retinal biopsy, which confirmed a metastatic mucinous adenocarcinoma. However, the immunohistochemical profile differed from the previous ovarian carcinoma, but showed similarity with the recent lung biopsy. So the ovarian tumor was CK20 positive, and the lung, core, and retina were CK20 negative. PAX8 was negative in the lung and retina, but was focal in the ovary. In addition, the ovarian tissue was P53 aberrant type, while the lung and retina were P53 wild type. And all tissues, ovarian, lung, and retinal, were all HER2 and NU positive. So here's a closer look at the tissue staining. Figure A to C shows immunohistochemical stain for CK7 or cytokeratin 7. It's a protein that is frequently expressed in benign and malignant glandular cells arising in different parts of the body, like the lung, breast, and the gynecological tract. And positive staining is shown in brown. So the lung shown in A and retina shown in C were CK7 positive, while the ovary, which is in the center B, was CK7 negative. Figures D and F show PAS stain for mucin The magenta color indicates the presence of mucin in the cytoplasm of the neoplastic glandular cells. And in this case, it's showing that in the lung specimen in E and the retina in F. So given all of these findings, the diagnosis of primary mucinous adenocarcinoma of the lung with metastasis to the retina was made. And so this was not CMV retinitis. In light of the immunohistochemical profiles of the retina and lung biopsy, a decision was also made to adjust her chemotherapy regimen to carboplatin, pemetrexed, and pembrolizumab, which is the common chemotherapy regimen for lung carcinomas. And after discussion with radiation oncology, a decision was made to hold off radiotherapy. So at 6 months follow-up, this is a photo, the patient completed their 5th cycle of this adjusted chemotherapy, and there was regression of her systemic and retinal lesions. Her visual acuity had decreased to 20/60 from 20/30, which was secondary to a cataract following the vitrectomy. The posterior segment examination revealed an otherwise healthy looking optic nerve with an attached retina. Here's just a closer look. The retinal lesion regressed and there was no appearance of active edges. There were laser scars where the biopsy was taken and the fellow eye continued to remain uninvolved. The OCT of the macula in the right eye was relatively unchanged from prior with a persistent ERM, and the OCT overlying the retinal lesion showed overall regression in the size of the lesion, as well as atrophy from the lasers. So some take-home points regarding retinal metastasis. Retinal mets is exceedingly rare. It accounts for less than 1% of intraocular tumors. The most common site of intraocular mets is the uvea, specifically the choroid. And this is because the choroid receives 85% of ocular blood flow as compared to the retina, which only receives 5%. Retinal involvement usually starts from the inner retina, which is supplied by the central retinal artery. As retinal mets grows, it replaces deeper retinal tissue. And after full thickness retinal involvement occurs, tumor cells can break through the RPE and Bruch's membrane and invade the choroid, or they can go the other way and break through the ILM and spread into the vitreous cavity. The most common primary sites for metastatic tumors to the retina are cutaneous melanoma, which accounts for over 50% of cases, followed by lung, GI, and breast carcinomas. And based on the literature, at the time of diagnosis of retinal mets, nearly 90% of patients have an established metastasis elsewhere and have a known non-ocular primary malignancy. With respect to symptoms, patients typically present with decreased vision, floaters. However, many can be asymptomatic depending on the size and the site of the metastasis, as was the case in our patient. So retinal mets is usually unilateral and solitary, but there have been case reports of bilateral and multifocal involvement. Metastatic melanoma typically presents as grayish brown pigmented lesion within the retina with irregular borders and flat appearance, as we can see in photo A. Metastatic carcinomas, on the other hand, tend to be non-pigmented, white or yellow in appearance with ill-defined borders and associated with retinal hemorrhages, as can be seen in photo B, and this was the case in our patient. These retinal lesions may appear elevated if there is presence of subretinal fluid underneath. Unlike choroidal metastasis, retinal mets may have associated vitreous cellular activity. Now, they present as spherules or globules in the vitreous, which helps distinguish them from vitritis that can be seen in infectious retinitis. Vitreous cells in metastatic carcinoma tend to be white and confined to the area overlying retinal involvement, as shown in photo C. And in metastatic melanoma, we can see more brown or pigmented spherules or globules, as shown in photo D. The diagnostic difficulty with retinal mets essentially lies in its rarity. There's often a delay in treatment. And the literature suggests an average of 5 months, mainly because of its resemblance to infectious or inflammatory retinitis and the prevalence of infectious retinitis being much higher in patients who are often immunosuppressed. So when dealing with oncologic patients with retinal disease, one should consider infectious or inflammatory retinitis and paraneoplastic syndromes on the differential. In patients with minimal initial response to anti-infectious therapy, a low threshold should be held for pursuing retinal biopsy to achieve a definitive diagnosis. As in the case we discussed today, a definitive diagnosis was achieved based on the pathology and the immunohistochemistry results from the retinal biopsy. And this was important because this allowed us to gear their chemotherapy regimen appropriately. And generally, there is a poor prognosis in patients who develop retinal mets with an average life expectancy of 2 to 24 months in the literature. Patient survival with retinal mets is far poorer than that with uveal metastasis. And to close the loop on our patient, unfortunately, our patient also did not have a good prognosis. They ended up passing away 4 months following resolution of their retinal lesions due to complications from surgical management of their bony metastasis. And that brings us to an end to the first case. Thank you for listening.
Thanks, Famida. That's clear and nice. Any questions to Famida? So basically, the message is that retinal mets, although rare, it can look like cytomegalovirus retinitis in a patient who's immunocompromised from an original cancer. So the patient under treatment, we don't know if this white patch is cytomegalovirus retinitis from his chemotherapy or this is actual metastasis to the retina, which is quite rare. And as she said, if we see no response to the antiviral treatment, we can proceed with retinal biopsy to reach diagnosis. Thank you very much. So I think I will present my talk. Wonder if you can see my slides. Okay, so I'm going to talk about conjunctival melanoma and what we know about it currently and how the treatment has changed over the years. So conjunctival melanoma is a rare but potentially lethal tumor and one of the aggressive tumors that may involve the eye. The incidence of which is 0.6 cases per million per year. That's almost 1/10 of what we see with uveal melanoma. It usually involves middle-aged and elderly patients with no sex predilection, and it represents 5% of all the ophthalmic melanomas. We discovered a UV signature mutations in the bulbar conjunctival melanoma. This UV signature is transversion between guanine and cytosine or double transversion of guanine and cytosine. And that's characteristic of cancer that results from solar exposure. We see it in bulbar conjunctival melanoma, indicating the importance of protection, UV protection, in patients who are predisposed. The origin of conjunctival melanoma is PAM with atypia in 75% of the cases. It arises de novo in 17% of the cases and from a pre-existing conjunctival nevus in just 8%. And let me just elaborate on that. If you see these slides here, I'm not sure if you're seeing my mouse moving. So normally melanocytes migrate from the neural crest to reside in the basal layer of epithelium or epidermis in the skin. And proliferation of those melanocytes in a spread fashion like this, we call it melanosis, or in cases that develop later in life, we call it primary acquired melanosis. So when we have monotonous cells, there is no atypia here. This is PAM without atypia. And when we have multiple cells in different layers of the epithelium, would have different configuration. This is PAM with atypia. When melanocytes proliferates in the form of a nest in the epithelium or the subepithelium, this is a nevus. And when we have the cells of various shapes and sizes and different shaped nuclei involving both the epithelium and the subepithelial tissues, this is melanoma. So how does it present? The most common presentation is like this, mass, brown mass arising from a primary acquired melanosis at the base. It can also arise without pre-existing PAM as a unifocal bulbar mass with feeder vessels, or it can be in the fornix. It can be diffuse, like a patch with variable pigmentations and some nodules. As we can see, presence of nodules tips you towards that there is melanoma formation and it's not just mere PAM. It can be very subtle and appears as a pigmented membrane near the limbus and can be missed. But if you have a fair-skinned individual with this kind of this kind of subtle pigmentation in a membrane, suspect that it could be an early melanoma in situ. It can be completely amelanotic, just like uveal melanoma. We have amelanotic conjunctival melanoma. The color also might tip you that it's a melanoma. It tends to be like kind of orangey red because of some pigment content, give you this tan orange color in comparison to the pink reddish color of squamous cell carcinoma. And it can be multifocal, particularly if it's recurrent, and it usually appears in the scar of the previously excised one as multifocal amelanotic. The common differential diagnosis for melanoma include an extensive nevus, and we can tell because of the presence of cysts within the lesion. Extensive PAM can look like a diffuse melanoma. However, it's usually stable over many years without change. A pigmented gelatinous squamous cell carcinoma can look suspicious for a melanoma, but if you see it in a dark-skinned individual, that gives you maybe the idea that it could be just squamous cell carcinoma. Extraocular extension of a ciliary body melanoma at the subconjunctival space, and cases of scleral melt from rheumatoid arthritis or the accumulation of episcleral nodules of macrophages that we see sometimes after plaque radiotherapy. You get the tumor necrosis, and it can, the melanophages that eat up the dead cancer cells can escape through emissary canal and accumulate over the surface of the sclera. And there is the entity of episcleral blue nevus. It's not connected to the conjunctiva. It's arising from episcleral melanocytes, the deep episcleral melanocytes, and usually these have a different genetic profile from those of the conjunctival melanoma. So the AJCC classified melanoma in terms of severity and liability for recurrence and metastasis into 40 categories. T1 is those on the bulbar conjunctiva, and they are further subdivided according to the quadrants involved. T2 are those non-bulbar, whether they are forniceal, palpebral, tarsal, or the caruncle, and also being divided into 4 categories. T3 are tumors of any size with local invasion to the globe or to the eyelids or the orbit or the nasolacrimal duct. And T4 when the cancer reaches the nervous system. T2 and T3 melanoma have higher local recurrence and metastasis, and they should be addressed aggressively from the beginning. And the median time of local recurrence in various studies range between 1 to 1.5 years. We also identified the driver genes of melanoma. They work through the MAP kinase and mTOR pathways. BRAF and NRAS work through the MAP kinase pathway. BRAF mutation is present in about 42-43% of the conjunctival melanoma. It carries poor prognosis, like it's associated with metastasis. However, there are drugs that work on it and help to suppress this pathway. BRAF and NRAS are proto-oncogenes, like they promote the cell division, while neurofibrin 1 carries poor prognosis mutation. It's a tumor suppressor gene similar to RB1 gene. So if you lose the 2 allelic gene, you develop conjunctival melanoma. There are other genes involved and epigenetic alterations that affect the course of the disease. And the microenvironment and the genetic profile of conjunctival melanoma is similar to that of skin melanoma. And there is a wide variety of genetic alteration in comparison to what we see with uveal melanoma. We only discovered like 3 or 4 altered genes. So the wider alteration of the genetics open the door for future targeted therapy that can help us to control this aggressive cancer. So how do we treat melanoma? The treatment obviously depends on the extent of the disease, the expertise of the treating doctors, and the availability of various treatment modalities. So surgery like excision and cryotherapy, excision followed by radiotherapy, modified enucleation in addition to adjuvant radiotherapy, and exenteration, which we try to avoid at all costs. Radiotherapy, different kinds of radiotherapy depends on the location of the tumor. Plaque radiotherapy that we use for intraocular tumors, we use it also for conjunctival tumors. Orthovoltage radiotherapy for superficial cancers, megavoltage for deeper ones, and proton beam radiotherapy. And the drugs, we use topical chemotherapy for diffuse melanoma or PAM with atypia. Now, as I mentioned, with discovering the gene mutations, we have systemic targeted therapy like vemurafenib and dabrafenib. And most recent is the use of systemic immunotherapy as a primary treatment for advanced conjunctival melanoma. So I'm going to give examples of the applications of the treatment options. So if we have like a primary localized bulbar melanoma with PAM and there's no scleral invasion, the treatment is by the standard procedure for limbal masses by alcohol epitheliectomy to remove the corneal component, and excision biopsy of the lesion, taking care of keeping the field dry so it doesn't disseminate tumor cells with no tumor touch technique. We apply cryotherapy at the surgical margin, and we close whether primarily or using an amniotic membrane or autologous graft, and that's usually curative in such situation. If you have a tumor at the fornix, which might be more challenging to excise, still can be excised by applying diathermy all around the base, excise with no tumor touch technique, applying cryotherapy, and that also can be curative. You can use topical mitomycin as a new adjuvant or as an adjuvant treatment, depends if there is dispersion of tumor cells within the conjunctival sac. Plaque radiotherapy, as I mentioned, is applied also in melanoma that has some scleral invasion. That we see in cases of recurrence. You excise the tumor, but still stuck to the tumor base, so you know that it will regrow, so better to apply a plaque radiotherapy in such case, and usually gives excellent results. So, for example, a case like this that came with a mass protruding on top of the eye, and you can see at the base there is a brown scleral nodule. So we decided to excise and maybe use episcleral plug to the scleral part. The surgical excision of the lesion confirmed a melanoma, and that also, again, no touch technique, is just we excised it at the base with a lot of diathermy, so we do not disperse cells. And then we applied the plug that worked on the intrascleral component and achieved full resolution. In case if the diagnosis is evident, we can do it always on one occasion. Like this is a recurrent brown lesion after it's been excised before in childhood and was diagnosed as melanoma. So there's no point in taking a biopsy. We go straight to excision biopsy, followed by cryotherapy at the edge, and we pull the edges under the plaque. So we cover a very wide safety margin outside the surgically excised part, and that achieves control with no recurrence. Orthovoltage radiotherapy is a good treatment for superficial tumors of the conjunctiva and the eyelid. So this case was a lentigo malignant melanoma that has been excised several times before, and it involved both the conjunctiva and the eyelids. So we started her on mitomycin as a neoadjuvant treatment to shrink the tumor as possible. And then we applied the orthovoltage radiotherapy, which controlled the disease. And there's been no recurrence for 5 years when she used to have recurrence after every excision, few months after every excision. Now she maintained her eye and the eyelids functioning for 5 years after radiation. High energy radiation like stereotactic photon radiotherapy, which is the one we use for visceral cancers, can still play a role with conjunctival melanoma if it's in the fornix or the anterior orbit. But it cannot be applied on surface melanoma because the energy is so high and can lead to scleral melting. So if there is a residual disease in the fornix or the anterior orbit, this can be the treatment of choice. So in complicated cases, we used to have this multidisciplinary approaches that we sit and we talk to the radiation doctors and the medical oncologist, and we, the ocular oncologists, put a treatment plan of the steps that we need to follow. So here's a case of a conjunctival melanoma that is occupying 3/4 of the bulbar conjunctiva with involvement of the insertion of the recti muscles and a big nodule extending to the orbit. So here the standard of care was in the past was just to do exentration. But the patient refused that, and we decided that it's possibly we can save the eyelids. So we proceeded by an extended inoculation. Extended here means like instead of just the globe, we take also the attached pieces of the tumor attached to the globe. And because we sacrificed most of the conjunctiva, we ended up with a contracted socket, but we managed to put a collar implant, a mid-pore implant. And the patient had her radiotherapy, and then we did socket reconstruction with an amniotic membrane. We dissected and created fornices. And we had an excellent cosmetic outcome. The eyes inoculated, but the eyelids are functioning, and that's could be achieved without the need for aggressive surgery like exentration. Also, another case where you have a disease all over the place involving the fornices with large masses, and melanoma cells are scattered on both surfaces of the conjunctiva, bulbar and palpebral. So again, we went into multi-step surgery of excising the large pieces of the fornices using the no-touch technique, and that how it looked like, just the scattered diffuse disease without masses. And we used an unshielded plaque, like the radioactive plaque without the gold shield, so it can hit, the radiation can hit on from both surfaces, from the front and back of the plaque. In these cases, we use something called bolus, which is a synthetic material that simulates the tissue, the human tissue, and the goal of which is to reflect the radiation back towards the eye. So no radiation is lost to the front. It's all stays within the conjunctival sac. And that's how we did it. We did 360 periotomy to separate the conjunctiva and sutured it over the cornea. So now the conjunctival sac is one continuum, and we foot pre-placed plug sutures and pre-placed tarsorrhaphy sutures. We put the unshielded plug to cover the bulbar conjunctiva of the Gunderson flap and fixed it in place to the lateral and medial canthal tendons. And after tarsorrhaphy, now the plug is working to irradiate both surfaces. This could eliminate all the pigmented cells that we could see, but left the patient obviously with severe dry eye. More recently, something evolved that changed the scene, which is immunotherapy. Immunotherapy employs natural or laboratory generated molecules to release the capacity of the immune system to identify and attack tumor cells. Here, we're not using cytotoxic drugs. We're getting the natural immune system to identify that these are cancer cells and identified. And that discovery won Nobel Prize in 2018 for treatment of skin melanomas with immunotherapy, which changed a great deal the prognosis of skin melanoma. So now we're using it for conjunctival melanoma. As I mentioned, it carries the same microenvironment and genetic profile of that skin melanoma. So immunotherapy has been used to treat metastatic conjunctival melanoma, but now we use it as a primary treatment for conjunctival melanoma. And it's a good treatment when you have a large disease that can stimulate the immune system. Like it wouldn't work if you have like small scattered melanoma. It's not cytotoxic. You need something to stimulate the immune system and use the immunotherapy to make the T lymphocytes attack the immune system. So now in large diffuse diseases, this is our treatment of choice to start with. Metastatic surveillance, the overall recurrence is 30 to 50%. As you can see, it's aggressive tumor, and the mortality rate is 20 to 30% at 10 years. This might be a little bit an old data because now, as I say, we have new drugs and we use radiotherapy, and so things are changing. The risk factor for metastasis is greater tumor thickness, non-bulbar location, as we see in T2 and T3 melanoma, low tumor pigmentation, histologic ulceration, and local invasion to nearby structures. So there is no specific agreement about the protocol for surveillance. Some centers use sentinel lymph node biopsy to look at the regional lymph nodes if they have micrometastasis, although there's controversy about whether early discovery of micrometastasis in local lymph nodes have survival influence or survival benefit over the regular periodic scanning by MRI or PET scan. Princess Margaret, we normally, cases that are high risk, we follow them with MRIs to the regional lymph nodes periodically every 3 or 4 months. For 3 to 4 years after treatment. In conclusion, I'd like to show you this case. So this is a patient that had a tarsal melanoma and had an excision elsewhere. Not excision, somebody took an incision biopsy, which caused dissemination of the tumor. This is a friable tumor, and the tears also help to spread it to the other parts of the conjunctiva and maybe to the lacrimal lacrimal passages. The diagnosis is evident. It's a brown mass in the tarsus, and you change a localized disease into a diffuse disease becomes a problem and hard to control. After many months of battling the disease with drugs and excisions and cryotherapy and so forth, we could manage to get it under control. However, 1 year later, the patient had a bloody epistaxis, and we found that she had a melanoma growing along the nasolacrimal duct. That's because of the tumor has spread at the time of presentation to the lacrimal sac and showed its face a month later. She had to go through a big surgery by the ENT surgeons, and she died eventually. So Based on that, there was a paper published a long time ago by the Shields group saying that the surgical technique of tumor management was found to be possibly related to tumor metastasis and death. Incisional biopsy should be avoided in conjunctival melanoma if you can diagnose it clinically. And there is a specific technique, it's beyond the scope of this talk here, to take a small biopsy if needed, if you're not sure of the diagnosis, if you have an amelanotic melanoma, or you want to look at the genetic profile to decide about the drug to give without causing tumor dissemination, because this is the cause of recurrence and metastasis. So to sum up, the immunotherapy and targeted therapy based on tumor genetic profiling have a rising role in the treatment of metastatic disease. And currently you use it as a treatment for a primary locally advanced conjunctival melanoma. The multidisciplinary approach in a specialized center with expertise to treat such a complex tumor that could combine surgery, radiation, and/or drug therapy provides the optimal treatment outcomes in conjunctival melanoma. Thank you very much. Any questions for me? I think I have one question here. Good morning, everyone. Thanks for joining. Yeah, that's not a question.
No, I just want to say thank you for sharing those cases. Those are all for the rest of us. You know, that's probably routine for you, but those cases are not routine for the rest of us. It's always fascinating to see the course and your management. So thank you for sharing those.
Thanks, Amandi. I think Tina can start because time is getting short. Go ahead, Tina.
Tina, you're just on mute.
Can you hear me?
Yeah.
Yes.
Perfect. Okay, thank you. It's a pleasure to present. So we'll start the presentation with a video from a show called Is It Cake? I don't know if you can hear the sound.
Sewing machines, but one of those sewing machines is a cake. Let's see if you can find it. Judges, you locked in number 4. Let's see how you did. Cut the red.
So in the setting of a reality show where you're dealing with cake, you can afford to make mistakes and misjudgments. But when it comes to patients, in particular dealing with cancerous or malignant lesions, we want to optimize our decision making. And so we'll go through a similar game called Is It Cancer? And so this will bring us to our first poll question. Which one of the following is a malignant or a cancerous lesion? So we'll bring up the poll question, cases 1 through 6. One of these is a cancerous or a malignant lesion. We'll just ask the audience to enter their answer in terms of which one they think is the cancerous or the malignant lesion. We'll give everyone a few seconds to input their answer.
Mark, how are you? Good.
A few more seconds. Results.
Okay, so it seems like option 3, 5, and 6 were the top choices. We'll go to the next question. So again, similar, which one of the following is a malignant or a cancerous lesion? We have options 1 through 6. One of these is a cancerous or a malignant lesion. We'll have poll number 2 put up, again with the numbers. We'll ask the audience to select one of these, which is a cancerous or a malignant lesion. We'll just give everyone a few seconds to input their answers. And I'll just make a note here. We'll go back to all of these options and briefly discuss what each of them are. But I'll first start with presenting 2 sets of cases that will discuss the 2 cancerous lesions.
Here's your results.
Thank you. So it seems like option 1 was the most popular, but we also have some votes for 2, 5, and 6. So we'll go through that shortly. Okay, so starting with case 1, 62-year-old female, 2-month history of blurry vision in the left eye. Heaviness was seen somewhere else a month ago, told that she had a lesion that was being monitored. No history of cancer, dry cough for weeks, night sweats. Vision in the unaffected eye, 20/25. Vision in the one that she's symptomatic in is 20/80. Anterior segment exam is completely unremarkable. These are this is the pseudo color optos images. You'll see multifocal infiltrative cream-colored lesions of varying sizes that are coalescing, diffuse pigmentary changes. There's no vitreous cells. There's a demarcation here of orange pigmentation that could be indicative of accumulation of lipofuscin. The fundus autofluorescence here demonstrates subtle RP modeling all throughout. So you'll see that alternated hypo-autofluorescence. Where the cream-colored lesion is, there's a very homogeneous slight hyper-autofluorescence, and most remarkable is this demarcation line here at the edge or the border of the cream-colored lesions, which is most has the highest reflectance. On the OCT macula, through the central macula, you'll see the vertical cuts. There's undulation, sub-RPE, and trace subretinal fluid. On the extramacular cuts, you'll see this homogeneous hyperreflective lesion in the choroidal space, which could be suggestive of an infiltrative lesion most commonly seen in lymphoma and METs. And of note, the retina is intact. The ultrasound demonstrated tumor thickness that was relatively flat, large crescent shape, low internal reflectivity, diffuse choroidal thickening that would be in keeping with an infiltrative lesion, and it is a multi-lobulated lesion. This is the images of the fellow eye. I'll point out here that there's very, very subtle pigmentary changes on the posterior pole. It's most notable on the fundus autofluorescence. You'll notice the, again, modeling, subtle modeling, alternating hypo-autofluorescence involving the posterior pole. And there's a very symmetrical crescent shape suggestive of an infiltrative lesion that is very similar to the other eye that we saw earlier. The patient had a number of basic investigations, mainly just to rule out typical infectious causes, TB, syphilis, and was referred to Princess Margaret Hospital. She had a biopsy done. This is another case of a patient with chandelier wide-angle viewing. This is an interlesional biopsy. In this case in particular, because of the elevation of the dome shape of the lesion, a non-bent needle was used, but in the patient that we were seeing, a bent needle was used due to the flatness of the tumor. And this is done with an assistant that provides suction, and you want to really avoid cutting through the retina while the biopsy is being done. The sample is then sent to cytology, analyzed, and demonstrated large cells with large irregular nuclei, prominent nucleoli, and scanty basophilic cytoplasm. This is most in keeping with large B-cell lymphoma. The patient had additional investigations, MRI orbits, MRI brain, MRI spine, all of which were negative. A PET scan was done, which showed no systemic or CNS disease, and this was mainly done because of the high suspicion for visceral or CNS involvement. And the diagnosis of diffuse large B-cell lymphoma, non-GCB subtype was made on immunohistochemistry. The patient was given an international prognostic index of 2, and this was based on the initial LDH levels that were abnormal in the patient's age, and this is a scoring system for determining their overall survival for the patient. Just a quick note on ocular lymphoma, incidence increases with advancing age, subdivided into non-Hodgkin's and Hodgkin's lymphoma. Diffuse large B-cell lymphoma is the most common lymphoma of the non-Hodgkin's type and accounts for 25 to 30% of the cases. This is just a set of the histopathology of ocular lymphomas, extramarginal zone lymphoma, follicular lymphoma, mantle cell lymphoma, and diffuse large B-cell lymphoma. A note on uveal lymphoma may have intraocular and extraocular components. Non-Hodgkin small B-cell lymphoma, mostly MALT, is the typical cause. Clinical signs will include choroidal, unifocal or multifocal infiltrates. Ultrasound will show uveal thickening, extraocular thickening. OCT will have that cystic appearance that we saw earlier on the OCT of that patient. Treatment includes ocular radiation. Prognosis is highly dependent on the type of lymphoma. MALT will have much better prognosis. Diffuse large B-cell lymphoma will have a poor prognosis and systemic associations. On the other hand, primary vitreoretinal lymphoma is a subgroup of primary central nervous system non-Hodgkin's lymphoma. 90% of these patients will actually have CNS involvement within 29 months. 28% of the patients that have CNS involvement will have concurrent intraocular involvement. It typically presents as a corticosteroid-resistant vitritis with patchy retinal infiltration. Some of the other clinical signs that are classically described are the vitritis that manifests as aurea borealis. This is gathering of vitreal fibers that kind of look like northern lights. And the leopard spots, which is a collection of subretinal pigmented lesions that coalesce, and this looks like a leopard skin pattern. Diagnostics are based on cytopathology, immunohistochemistry showing monoclonality, cytokine ratios of IL-10 to IL-6, which is highly sensitive and specific, and PCR more recently actually very useful for detecting MYD88 gene mutations, L265P, and IgA gene rearrangements. In terms of diagnosis, chororetinal biopsy or needle aspiration of subretinal deposits is gold standard, and additional imaging is typically required or investigations is required due to the high associations with systemic manifestations, as well as for staging requirement and determining extent of disease. In this case, the case was a little bit unusual because primary choroidal lymphoma most frequently is associated with a low-grade lymphoma, such as MALT, and an aggressive form of primary lymphoma, such as diffuse large B-cell lymphoma, involving the choroid is relatively rare. In terms of the management, this patient was discussed at the Multidisciplinary Cancer Conference. She was planned for R-CHOP plus radiation. This was a decision that was made due to the aggressive nature of diffuse large B-cell lymphoma, as well as a high suspicion for subclinical systemic disease. In terms of the prognosis for these patients, the prognosis has significantly improved over the years with the advance in chemotherapy compared to radiation alone previously, and the specific types of germinal center cell type versus the activated B-cell type have different prognoses as well, with GCB having a much better prognosis. In terms of diagnosis, these are difficult diagnoses to make. So primary vitreoretinal lymphoma and choroidal lymphoma are challenging to identify. They have a number of mimickers or indolent coarse and invasive diagnostics. And at least for primary vitreoretinal lymphoma, there's been several advances in terms of using aqueous tumor samples for identifying MYD88 with PCR, as well as advanced imaging techniques as a way of identifying these patients much better. Differential diagnoses to consider: amelanotic melanoma metastatic malignancy as a part of the neoplastic conditions, as well as a number of other non-neoplastic conditions, including infectious causes such as syphilis, TB, and non-infectious causes such as multifocal choroiditis. So this was the case that we saw earlier as a part of the poll. So the answer was number 2. I'll just go through the other ones, which are syphilitic posterior placoid choroidititis. This was sclerochoroidal calcification, which I think was one of the top choices. AMD, age-related macular degeneration. This is choroidal tuberculoma and miliary tuberculosis. And this was HSV, acute retinal necrosis. Okay, so we'll go through case 2. 61-year-old male, blurred vision for 2 weeks, history of hypertension, dyslipidemia, unintentional weight loss, no history of tobacco use, worked as a dental hygienist. Vision is 20/20, and the affected eye vision is 2100. Pressure is very high at 52. An anterior segment exam is completely unremarkable in the unaffected eye. This is her SLAM photograph. You'll see mild diffuse injection of the conj, no feeder vessels. There's most prominently this inferior fluffy lesion occupying the inferior half and the angle. There are faint KPs that you'll note here, satellite fluffy white lesions involving the pupillary margin. There's neovascularization of the iris and posterior synechiae. And of note, the posterior segment exam is completely unremarkable in both eyes. UBN demonstrating irregular thickening of the inferior portion of the iris. This has internal, medium internal reflectivity, invasion of the iridocorneal angle. It's really hard to differentiate this lesion from the iris, but it does appear that the ciliary body and pars plicata are of normal shape and thickness. There are some areas of optically empty cavities that could be either vascular channels or areas of necrosis. In terms of the interim, the patient had a high tumor burden with invasion of the angle, and their pressures were high, so they were managed topically in addition to acetazolamide. They were put on steroids. They had a fine needle aspiration biopsy that confirmed the diagnosis of epithelial neoplasm favoring lung adenocarcinoma. This is the fine needle aspiration biopsy, and you'll see that this can be done either intraoperatively or at the slit lamp. You want to provide counter pressure on the other side, which is being done here. It can be done with either a 25, 27 gauge or a 30 gauge needle, depending on the size of the tumor and how fluffy or solid it is. There's a short tubing, and the assistant is providing suction for you slowly. In terms of the disease course, so in the interim, the patient did end up developing within a few weeks lightheadedness, ataxia, inability to ambulate. They had multiple investigations done at other sites, had metastases that were identified to the brain, the spleen, the bone, and lymphadenopathy, as well as the right lower lobe lung mass. And the confirmed diagnosis was a metastatic EGFR mutant non-small cell lung cancer. They were started on chemotherapy. They had whole brain radiation and ended up needing a craniotomy due to the extensiveness of the tumor and a tumor-associated hemorrhage. And you'll see here on their MRI brain with GAD, there's multiple, innumerable number of enhancing brain lesions. Quick note on lung cancer, leading cause of cancer-related mortality worldwide. Risk factors are age, smoking, and male sex. A small percentage of these actually present when they're localized. So vast majority have already metastasized by the time they present. Non-small cell lung cancer accounts for the vast majority of the lung cancers, and a subdivision of these includes adenocarcinoma. The EGFR mutant variation is an important one to recognize. It accounts for 10 to 15% of the lung cancers. It is commonly associated with adenocarcinoma type, as was seen in our case, people who have never smoked, which was also in our case, and people of Asian descent. These mutant tumors actually have a better prognosis than the wild type, and there are targeted treatments that have been identified to target this mutation that have really improved the survival of these patient population. With regards to ocular metastases, choroid is the major site of ocular mets from lung cancer, and the primary cancer site in all iris mets actually includes breast as number 1 and lung cancer as number 2. There have been previous reports in the literature identifying iris mets as the first sign of lung cancer, and this is a case of a small cell lung cancer where the patient has a fluffy lesion very similar to our patient, involving their iridocorneal angle and a very prominent vascular invasion as well. So some of the other differential diagnoses to consider for intersegment tumor and pseudohypopion are neoplastic conditions, non-neoplastic conditions, including infectious and non-infectious etiologies with a wide differential diagnoses included here. I'll wrap up by showing the poll question that we saw earlier. I think the vast majority of people did choose number 1, which was great. Number 2 is reverse hypopion formed by emulsified silicone oil in the anterior chamber. Number 3 is a crystalline pseudohypopion. This can be seen in a multitude of conditions, including multiple myeloma. In this case, is seen in clusterosis bulbi in the context of chronic retinal detachment. This was a case of a calcium crystals in the anterior chamber due to primary hyperparathyroidism, was published by our beloved Dr. Halp Chu. This is a case of a tuberculosis uveitis presenting as pigmented hypopion, and this is a case of a presumed termitoid-induced granulomatous anterior uveitis. So I'll end off there, thank the following individuals, and thank you for your attention.
Yeah, that was fantastic. That was a whirlwind. I don't know how you pulled that all off, but thank you. That was great.
That was great, Tina. You made it. Okay. Any question from the audience? I think we still have 1 minute. Great. So thank you very much. That was great. And I think the message from Tina here, when you have a multifocal choroidal amelanotic placoid lesions like this, think choroidal lymphoma, that's one of the presentations. And choroidal lymphoma, as she mentioned, may be associated with extraocular lymphoma and visceral lymphoma. So it's good to examine also the conjunctiva and the orbit, which would be easier to biopsy than the choroid. And in her second case, also think of metastasis to the iris when you see multifocal or precipitation of a melanotic lesion like what we've seen. In this case, a needle biopsy will tip you towards that this are cancer cells, and you go for systemic investigation to find the primary. Okay, thank you, everybody, and looking forward to see you again in the near future.
I agree. Thank you, Tina, Famida, and Dr. Krema. Thank you for your wonderful rounds this morning. Thank you.
Thank you.